Bismillahirrahmanirrahim. Dear students, Assalamu alaikum. I think these type of classes are helpful for you. Today, I'm going to take class on X-ray with OSPE and practical exam orientation. This is Professor Mahmuda Hassan, Professor of Pediatrics of Ad-Din Women's Medical College. This is our first X-ray. X-ray skull lateral view showing widening of the diploic space. This one is the diploic space. This is widened here, but here the diploic space is normal. It is widened in the parietal bone and widening in the frontal bone. Second point is hair on end appearance. Here you can see the hair on end appearance of the flat bone, that is on the diploic space. Hair on end appearance from here to here, here to here on end appearance. You can see that something like here, but it is actually the changes within the diploic space of the skull bone. An obliteration of the outer table of the flat bone, that is the inner table flat bone. Flat bone, this is the parietal bone, this is the frontal bone, and this is the inner table, the dark mark line, and there is no line outside, that is obliteration of the outer table of the flat bone. So this is an X-ray of a child with hemolytic anemia, probably thalassemia. Here, this is an X-ray skull AP view. This is an X-ray skull lateral view. I have already shown the points on lateral view. Let us see on AP view. Here, widening of the diploic space visualized on parietal bone on both sides, right and left side, and here on in the appearance is visualized here, but here it is more prominently here on end appearance of the flat bone. And this is inner table, and this is outer table. Here you can follow the inner table, and here inner table of the flat bone, inner table. And if you start from here, the outer table, here outer table is here, but there is no outer table is visualized on both sides of the parietal bone. And you can see an area outside the parietal bone. This is the scalp that is present over the skull bone. Scalp means skin, S, C, connective tissue, A, aponeurosis, L for loose areolar tissue, and P for periosteum. So outside the parietal bone, here is scalp. The probable question for OSPE examination or on Viva, you may ask for identify the X-ray and write down the positive findings of this X-ray. What is the radiological diagnosis? Write down the principle of treatment of this condition. How will you investigate the child, like that? Or how will you treat the child? Principle of treatment of, as I have said already. The next X-ray is, this is an X-ray of wrist joint. Here, see the wrist joint first. A view is not mentioned here, so you don't need to mention the view. The wrist joint including the lower end of the radius, ulna, carpal, and metacarpal bones. Showing cupping. This one is cupping. There is normally at the end of the bone there is a smooth line, but here there is no smooth line. It is cupping, fraying, irregular lines. That means in Bengali we can say fraying মানে ছিঁড়ে ছিঁড়ে যাওয়া, and widening of the lower end of the radius and ulna at the metaphysis. Here widening of the lower end of the radius, lower end of the ulna, and the fraying and cupping like that, cupping. And there is wide gap between the epiphysis, this one is your epiphysis, and the metaphysis, and density of the shaft of the bone is reduced, and there is deformity here. You can see in the here deformity of the long bone, and you can see here also the greenistic fracture. Fracture is there, but there is no gap between the fracture. So these are the points here you can see in this X-ray. So here same thing. Another point I want to mention here, these two are carpal bones. These are not epiphysis. Here is the epiphysis. Here at the ulna there is no epiphysis. That is the ossification center of the ulnar epiphysis not yet developed. That's why you cannot see the epiphysis on the ulna. Where is my cursor? Cupping, it is well marked here. Widening of the ulna, widening of the radius, but cupping is not here, and fraying, and the gap between the epiphysis and the metaphysis, increased gap between the epiphysis and the metaphysis, and osteopenia. These are two carpal bones. Remember that. Again, widening, cupping, fraying, increased gap between the epiphysis and the metaphysis. So what will be the probable questions here? Identify the X-ray and write down the positive findings of this X-ray. What is the radiological diagnosis? How will you treat the condition? How will you investigate a child for the diagnosis? What are the clinical features of this condition? Another X-ray of scurvy, X-ray knee joint, including both the knee joints, including the femur, tibia, fibula, ankle joints. So what are the positive findings here? The ground glass appearance of the long bones of the lower limb. That is the femur and tibia. It is well visualized here. Ground glass means ঘষা কাচের মতো হয়ে যাওয়া. And pencil thin cortex. Pencil thin cortex. Here you can see the pencil thin cortex. What do you mean by pencil thin cortex? Suppose I don't have any pencil in my hand now, but suppose this is a pencil. Is it thin like that? No. The pencil having a lead having a point, and it is thin like that of the lead of your pencil. So it is so thin, it looks like pencil thin. That is the tip of the lead of your pencil. It is thin like that. So where is the pencil thin cortex? Here. Here, this line is, you can draw the tip of a pencil over the cortex. It is thin like that. Thin, pencil thin cortex. Pencil thin cortex. And first of all, come to the point here. We have already told about the ground glass appearance and the pencil thin cortex of the long bone. Here come to the point, white line or dense zone of provisional calcification. It is also called white line of Frankel's. This one. Here the Frankel's white line. Frankel's white line. Frankel's white line, it is not visualized here. So the dense line, you can see here, it is called Frankel's white line or dense zone of provisional classification. You can say just Frankel's white line. And underneath the Frankel's white line, there is a radiolucent area. Here, radiolucent area. Radiolucent area, which is also called fracture zone or lucencies at the metaphysis or rarefaction. Rarefaction or fracture zone. And small corner fracture or corner spar. Here, this is called corner spar. Here you can see the corner spar. And it is projected medially or laterally from the Frankel's white line. Here, corner spar. And ringing of the epiphysis. The epiphysis is surrounded by a white line. It is called ringing of the epiphysis. And it is also called Wimberger sign. It seems to be a burger. Here the flat surface of the burger and the convex surface of the burger. So it is also called Wimberger sign. W-I-M, Wimberger sign. And the periosteal elevation due to subperiosteal hemorrhage, I'm going to show you in my next slide. Here again the dark arrow showing the corner sign and the dotted arrow showing the Frankel's white line. And here you can see the epiphysis surrounded by a margin. It is called ringing of the epiphysis. Here you can see white line and the corner sign. Again, I have already described this X-ray, and here you can see the periosteal elevation due to subperiosteal hemorrhage. Periosteal elevation with subperiosteal hemorrhage due to subperiosteal hemorrhage, and it is the late manifestation of the scurvy. So what are the probable questions? Identify the X-ray, write down the positive findings of this X-ray, and what is your radiological diagnosis? How will you treat the condition? what are the clinical features of this condition, like that. And the last X-ray, X-ray chest AP view, it is a X-ray of bronchiolitis. Here we can see hypertranslucency, more blackening, blackish lung field. Here lung fields are blackish, and hyperinflation, which is recognized by looking at the horizontal ribs. Ribs are more horizontal rather than oblique, and depression of the domes of the diaphragm. It is level is much more lower than that of the normal level. Here the level is 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, almost below the 11 rib. At the level of the 11 below, you can see the lung field is extended up to 11 rib. So there is depression of the domes of the diaphragm. It is supposed to be at the 7th or on the back at the 9th level. Below the 9th, maximum on the 9th rib. Below the 9th rib, it is hyperinflated. In children. So identify the X-ray and write down the positive findings of this X-ray as I have mentioned. And what is your radiological diagnosis? It is the radiological diagnosis is bronchiolitis. How do you treat the condition? How do you investigate the child for the diagnosis? Few points on hyperinflation. I'm talking in children, usually films are taken AP view, but here in adult, here the picture showing the how to take a PA view. On inspiration, diaphragm descends up to 10th rib. If the diaphragm is not at the 8th rib, lung is there is hypoinflation of the lung. And if the diaphragm is past the 12th rib, that is hyperinflation. It is in adult. How you can explain the hypoinflation and hyperinflation in adult? So normal level of the okay, 9th rib, normal inflation. Here normal, how can you say it is not hyperlucent? That is the normal lucency, lung with normal lucency. How we can explain? Lung should appear black on most film. Normal lung should include thin white lung marking that extends almost to the periphery of the lung field. That is the bronchovascular marking. These are extended up to the periphery. This is the normal lucency of a lung field. If it is like that, the bronchovascular markings are extended up to the periphery of the lung field. So it is a normal lung field. And diffuse bithoracic hyperlucent lung, hyperlucent and hyperinflation as well. Diffuse increased lucency present in both the lung field. In normal, you may see in if a normal child who has taken deep inspiration and X-ray has been taken in this deep inspiration, and hyperlucent may be a overexposure of the film, and hyperlucent lung film you may get in bronchial asthma. Hyperlucent lung film, as I have said, it is in bronchiolitis as well as in cystic fibrosis. And the penetration, it is under penetration. You cannot see the vertebral body through the cardiac shadow. Normal penetration, you can see the vertebral bodies through the cardiac shadow, and this is over penetration. The lung fields are more darker than that of the normal lung field. But here you can see the vertebral body. So by looking at the lung field, it is more darker, it is over penetration, it is normal penetration. Here you can see the vertebral bodies of the vertebra clearly over the cardiac shadow, and in under penetration, you cannot see the vertebral bodies. So this here, good penetration, you should be able to see the thoracic spine through the heart. And you have to know lots of things on X-ray chest. You have to know the how to read an X-ray chest, and what are the how can you define the upper zone, middle zone, and lower zone. What is hyperinflation? I have explained. What is and you have to know cardiomegaly and how to explain the cardiac shadow is enlarged. This is a vast subject, how to read an X-ray chest. And you have to know the pneumonia, like lobar pneumonia, bronchopneumonia from X-ray chest, pleural effusion, pneumothorax, and then hydropneumothorax, and tuberculosis, like that. Lots of things will come from your X-ray chest. So this is a big portion, big subject, big chapter regarding the X-ray chest. I have only discussed on X-ray chest of a child with bronchiolitis. Thank you all.